I am Bernard Herschel. Before my retirement, I was the chief of HIV/AIDS at the Geneva University Hospitals. You may call me an AIDS dinosaur who has followed the HIV epidemic from the very first cases in the early 1980s through the triumph of antiretroviral therapies, a triumph unequaled in the annals of medicine. This triumph has its flip side. Younger colleagues are no longer familiar with the opportunistic diseases and the myriad manifestations, hence the idea of these videos. After a short introduction, they will show a series of images illustrating one or several exemplary cases from my files. Mycobacteria other than tuberculosis, or MOT. Patients with extremely advanced immune deficiency, the median CD4 count is less than 20 per microliter, present with fever, loss of weight, and digestive symptoms such as abdominal pain and diarrhea. These are generalized infections with positive blood cultures and involvement of the liver by granulomatous hepatitis. 80% are due to Mycobacterium avium. In this graph, the yellow line represents the falling CD4 counts during the progression of untreated AIDS. Pneumocystis pneumonia typically occurs in patients who have around 100 CD4 cells per microliter, Toxoplasma encephalitis at around 50 CD4 cells per microliter, and MOT when CD4 cells have nearly all disappeared. Patient 1 was a woman born in 1959, an IV drug user, HIV positive since at least 1981, and imprisoned in 1984. In 1985, she lost weight, then had seizures due to cerebral toxoplasmosis. She responded to therapy with sulfadiazine and pyrimethamine. But in 1986, weight loss continued, fever appeared, the liver and spleen were enlarged, and blood cultures show Mycobacterium avium intracellulare. And despite treatment with rifabutin and clarithromycin, the patient died in August of 1986. This image is from a liver biopsy showing granulomatous hepatitis. An enlarged picture of a hepatic granuloma. In this low power view of the duodenum at autopsy, colored with an acid-fast stain, the submucosa is completely occupied by macrophages laden with acid-fast red mycobacteria. This image, taken from another case, shows massively enlarged mesenteric lymph nodes. The invasion of lymph nodes and of the submucosa explains the weight loss, malabsorption, and diarrhea. High power view of macrophages filled with acid-fast bacteria from enlarged lymph nodes in a patient with AIDS. Mycobacterium tuberculosis, MTB left, and M. avium right in acid-fast stains. MTB is generally less abundant and shorter, commas, than MAI, knitting needles. Opportunistic diseases, and in particular non-TB mycobacterial diseases, MOTT, may become apparent or flare up after starting highly active antiretroviral therapies. This phenomenon is called immune reconstitution inflammatory syndrome, or IRIS, and is treated in detail in another video of this series. These two graphs from the Swiss HIV cohort study show the incidence of PCP and MOT in relation to the start of HAART. Most infections behave like PCP, with a marked fall in incidence already in the first 3 months after starting HAART. Not so with MOT, where incidence first rises before falling. A graph of survival versus time after diagnosis of MOT. Survival was dismal before the advent of HAART. The difference after the introduction of highly active antiretroviral therapy in 1996 was dramatic and shows that even patients whose immune system was almost completely destroyed can recover. On to case 2, which led to the discovery of Mycobacterium genavense. This was an HIV-positive intravenous drug user born in 1960. In 1988, he had a CD4 count of 45 with loss of weight, fever, enlarged liver, and ascites. Liver, duodenum, bone marrow, urine, and fecal samples show acid-fast microorganisms, but all cultures remained negative. He was treated with clarithromycin, ethambutol, and rifabutin with transient improvement. Acid-fast bacteria appeared in ascites and even in the buffy coat. He then developed hepatorenal syndrome and died after an evolution of 11 months. An acid-fast stain of duodenal mucosa at autopsy. All the red areas represent Mycobacteria. An acid-fast stain of buffy coat from blood at autopsy. Besides partly degraded leukocytes, masses of Mycobacteria are seen. Here are the results of our tries to grow the mysterious Mycobacterium in culture, showing the growth curves in comparison. The assay measures the production of radioactive CO2 from palmitoic acid. Whereas M. avium shows vigorous growth after 14 days, Mycobacterium genavense's growth curve remains indeterminate and peters out after a month or so. What to do with bacteria that won't grow? We put them in a culture of human macrophages, where adding the patient's spleen tissue with an estimated 10 to the 6th acid-fast rods produced incorporation of radioactive thymidine, evidence that something was growing. Or we used chromatography to compare the constituents of the cell wall, showing that extracts of patient's duodenum, full of Mycobacteria, differed from extracts of other Mycobacteria. A picture of 2 mice, one normal, one grey, immunosuppressed. In these grey, nude mice, Mycobacterium genavense could finally be made to grow, as seen by the macrophages in the liver on the right, which were full of Mycobacteria. These findings were published in 1988 with the title Fatal Infection with a Novel Unidentified Mycobacterium in a Man with AIDS. In the meantime, several colleagues told me that they had had the same problem with Mycobacteria that won't grow. It so happened that my secretary was ill. Human Relations sent me a male replacement. Unfortunately, his secretarial capacities left somewhat to be desired. So instead of losing my temper while correcting his letters, I decided to type them myself and instead sent him on a tour of Switzerland, armed with a big thermos. He came back with a collection of frozen biopsies. But what now? There were quite a few suspected cases. But to prove that they had the same cause, it was not enough to show that some red stuff seen in the microscope, suspected to be Mycobacteria, won't grow. And to repeat for each patient animal experiments, chromatography and macrophage culture was much too expensive. I contacted every mycobacteriologist I could think of for advice, but made no headway. Out of the blue, the telephone rang. It was some Eric Butker, who told me in no uncertain terms that I was looking in all the wrong places and that I should use his revolutionary method for bacterial typing instead. Taken aback, I asked around and was somewhat discouraged to learn that he was a complement researcher, very recently interested in Mycobacteria and known to be somewhat arrogant. But then he sent me a preprint of his paper. It didn't take me long to convince myself that he was right. And his was a method to revolutionize identification of bacteria, and Mycobacteria in particular. I visited him in Hanover and we started to cooperate. In Eric's lab, ribosomal RNA was extracted from tissue, reverse transcribed, amplified and sequenced. Here we have the reference sequence of Mycobacterium tuberculosis on top, then the sequence extracted from the patient's sample, followed by several other Mycobacteria. The sequence of the patient's bacterium was distinct from those of known Mycobacteria, establishing a novel species called M. genavense. We described 18 cases in the paper in The Lancet, and many more were collected through the HIV cohort study. M. genavense has thus become a recognized pathogen in AIDS and in other immunodeficiencies. It is even much more important in birds, where it is present in a high percentage of autopsies, with 40 publications in PubMed. And Geneva now has not only a lake and a fountain, but also a Mycobacterium to her name. Thank you for watching, and thanks in advance for your feedback. This video is part of a series on opportunistic diseases in HIV/AIDS. If you are interested, please subscribe or click on the latest upload top left.